got lots to get through. My name is Simon Turner, and I'm going to be hosting today's excellent Engaging Evidence 2021 session, Statistical Issues in Meta-Analysis. Just before we get started, each presentation is due to run for 15 minutes, 10 minutes, and then a few minutes for questions as well. I'll hold up a very fancy looking 2-minute warning sign when there's 2 minutes to go, just to let you know that it's just about up. We should have a few minutes for questions after each presentation. And if you do have a question, please feel free to type it into the chat window, or you can use the little raise hand icon. The presentation is recorded, but the recording is only including the presentation and the speaker, not the question time or your personal videos. I do ask though that while the presentations are on, that you keep your microphone on mute and turn your video off to save bandwidth for those who have poor internet. Thank you very much. We'll move straight on with the presentations. First up, we have Gianluca.
Simon, and thanks everyone. It's very exciting to be with you all. And without further ado, let me really go through a humble proposal that we are putting through, advocating the use of Bayesian meta-analysis, especially in the context of living systematic reviews on prospective meta-analysis. I'm Gianluca Di Tanna. I'm the head of biostatistics unit at the George Institute for Global Health. And recently we also set up a unit which I co-lead with my colleague Soumyadip Bhowmik, with whom, and with Anthony Sunaya, Joseph Santos, and Robert Grant, we are working on this proposal, which it's been called Call of Duty, but wants to be more a humble proposal, which is probably might be a nice fitting for living systematic reviews and PMAs. I just declared that I don't have any conflict of interest. And for this proposal, no funding has been received, at least yet. Other important point, I really like to acknowledge the traditional custodian, the land from which at least I present today, the Gadigal people of the Eora Nation, and pay respect to the elders past, present, and emerging. The outline of my presentation is really regarding the setting the scene of LSRs and prospective meta-analysis. I will quickly go through, as I guess most of us are all very familiar with the classic meta-analytic model, the potential issues in LSR and PMAs, the very brief presentation of the Bayesian approach, and I will guide you through a recent example of a living systematic review. And then I will wrap up just trying to advocate more for the Bayesian meta-analysis. I think, and also Julian Elliott this morning talked about the living guidelines and living systematic reviews. Now, as the evidence is very rapidly accruing, we see nowadays 70 trials a day or more are accumulating. Many of these, unfortunately, are underpowered to detect differences in some of the relevant clinical outcomes. We know that the time to produce systematic reviews is not so short, and quickly they become obsolete. And we are also witnessing an epidemic of systematic reviews. Nowadays, we know we're seeing published more systematic reviews than actually primary studies, with several overlaps. So the idea is really to register a systematic review and keep that updated with a specific and predefined frequency. So the idea is that the evidence is gradually accumulating and can inform and update the previous findings. I'm not going to tackle here any issue around the methodology of the review, the extractions, the inclusion or exclusion of preprints, if including a meta-analysis, only the studies are low risk of bias, which outcomes, and the best and the most appropriate frequency of the updates. This is a clear link to what is now being called the living prospective meta-analysis. Anna-Lene Seidler made this proposal, which is very appealing to basically new studies to be included as they are being planned, but importantly, before any of the results related to the research questions are known. This is because, of course, we don't want that the knowledge of any study results could influence the hypotheses or the selection criteria of the studies. Typically, the prospective meta-analysis goes ahead and continue until a definitive effect, a definite answer has been assessed, or the maximum required statistical information has been reached to conclude that the clinical important effect has been found. Although we could relax these specific stopping rules and just saying, okay, we'll keep on updating the review. These are also the perfect settings for establish good collaborations, ideally also to share individual patient data, which is another important topic for which unfortunately I don't have now the time to discuss further. How do we usually, and now we're just talking about the aggregate data meta-analysis. How do we usually pull the evidence? We collect the study effect size, YIs, and the standard errors, the sigma i's, and we usually deal with what is called a random effect model, which is basically a normal hierarchical model. This is usually done with a latent two-stage approach. First, we estimate the tau, the between study heterogeneity. Unfortunately, we must say that especially in the classic, in the fragmentist version of the meta-analysis, this goes neglected. We rely on the classic Dersimonian Laird, or we know by simulation empirical studies, the Arthur-Knapp, Siddiqui-Onkman estimates of tau are better suited. But in general, the tau goes just hidden in some of the tables of the forest plot, and actually is not even commented at all, while we're just more relying on the I-square with all the other issue of saying if it's a quantitative heterogeneity or actually is a proportion attributable to heterogeneity. The main issue here in general is that heterogeneity is commonly underestimated. In fact, when tau is equal to 0, we revert to the fixed effect model. Whilst actually the assessment of the heterogeneity is a crucial part of meta-analysis. And once that we have the tau, we can estimate the actual effect. In other words, we have two parameters, the true parameter effect size and the heterogeneity. Now, going back to the living systematic reviews and prospective meta-analysis. Updating meta-analysis means a constant reanalysis of the data, and with repeated analysis of accumulating primary studies. This means that we have an inflated rate of false positive, and especially if we do statistical tests that are repeated naively. So that means that we could reach spurious conclusion, especially if we solely rely on the dichotomized appraisal of the p-value. Further, effect estimates are especially unstable at the early stages of any review. And also the estimate of tau is crucial when we have early evidence and we don't know exactly what it is. So these are all relevant to any updates of meta-analysis or other points at the any meta-analysis, and particularly important for living systematic review and PMAs, especially given the potentially frequent updates of these reviews. We have statistical monitoring of meta-analysis that use sequential methods that can control the risk of this spurious finding. And we can keep the pre-specified power at the clinic to identify clinical relevant effect sites. We have adjustment of p-values. We can rely on the classic Bonferroni. We also have midway adjustments such as the Wetterslev to keep the family-wise error rate less than 0.05. But again, that is the problem, which basically we rely on a p-values above or less than a specific threshold. Then we have also sequential methods, but these are basically more based on testing rather than on the estimation. And that might be a problem. So the proposal is really to go through a very natural framework. And in the words of Julian Elliott, when he first proposed the living systematic review, he was advocating already the use of Bayesian meta-analysis, which basically we monitoring the accumulating evidence, and the prior distributions can be used to reduce the problem of concluding superiority of an intervention. Already 2 minutes. So basically the idea is to update the prior information through the data that we see to get the posterior of the data. We have the two distribution, the two prior distribution, the mu and the tau. and we can place appropriate priors. And we get, the good thing is that we can get posterior distributions, conditional posterior distribution, and we can evaluate in an intuitive way what is the probability that the intervention is effective. And we have also a nice plethora of accessory information, again, in the Bayesian context. Just to cut through the examples that I wanted to tell you is regarding a living systematic review of COVID in asthmatic patients. We did already 2 iterations of the meta-analysis. As you can see in the cumulative classic random effect meta-analysis, we were in the verge of calling a statistically significant increased risk of hospitalization for the asthmatic patients versus the non-asthmatic, but we couldn't call that off again yet. Doing a Bayesian meta-analysis, we could estimate what is the probability that asthmatic patients have an higher risk of hospitalization. And actually that is worryingly high, it was 96.7%. And that is actually the probability, the posterior probability of the effect size, of the pooled effect size. We can get the overall posterior of the distribution of the pooled effect. And this was based on a flat prior. I won't go into the details of the flat prior, which has heavy tails and they might be even improper. What if we could have done a Bayesian meta-analysis using some of the historical accumulated data, for instance, the end of January 21? We could have gotten a 98% of probability that the actual asthmatic patients have a higher risk of hospitalization. We can see that in the violet curve that now the posterior is slightly more informative, and this was based using the prior, which is the historical prior of the information that we got until January 21. Just to cut the very long story short, the Bayesian meta-analysis is really natural and flexible approach where we can specify prior information using the information accumulated until a specific time, and that before the data is taken into account. In other words, today's posterior becomes tomorrow's prior. We can make probabilistic statements where results are more easily interpretable without relying, again, on a p-value less or higher than a 0.05. The heterogeneity is, and the uncertainty of the heterogeneity is explicitly taken into account. We cannot make any, we not rely on any asymptotic assumptions, so the results are valid also for small sample sizes. And nowadays, Bayesian packages are really everywhere, and we are also developing a nice, user-friendly, shiny tool where we can actually play with the Bayesian meta-analysis in a very user-friendly. Plus, we can also run meta-analysis using both aggregate data and individual patient data and mixture of them. Very last point, we are setting up a critical mass of Bayesian meta-analysis in the head-to-head context. And we have now setting up a Bayesian-ma.net website where we're gonna upload all the material on that. And you can also, Fanny, follow me on Twitter. I will try to be active in the arena. Thanks, everyone.
Thank you very much, Gianluca. That was fascinating. I have not done a lot of work with Bayesian meta-analyses, so it's just so interesting to hear the different options that are available there. I'll open up for some questions now. We have a minute or two for questions. Feel free to either put your hand up or just ask a question in the chat. And of course, if you think of something a little down the track, oh, here we go. Is a question up already. Thanks for the great presentation. Is it possible that historical prior using can introduce bias?
Well, first of all, that's a good point. It's important that we really want to be transparent. So doing also, for instance, sensitivity analysis and trying different priors, because of course priors are important. As in the examples that I show you anyway, even if I were using objective historical priors, the results of the posterior were not so different of using an a priori and flat prior. Of course, it's important, especially if you use, say, a subjective prior, which is completely skewed to pressure test that prior. So, of course, transparency is key because the prior is an element of the analysis.
Excellent, thank you. In the interest of time, if you've got further questions, feel free to put them in the chat, or maybe if we have some time afterwards, we can move on to them there. So thank you very much. Next up, we have Elizabeth. Would you like to Oh, here we go. Excellent.
Sorry, I was on the ball for sharing my screen, but not my voice. So hi, everyone. I am a PhD student in the Methods for Evidence Synthesis unit at Monash University. And I'm going to be talking to you about a simulation study that I've undertaken to examine the statistical approaches to use meta-analysis for a particular study design called the Interrupted Time Series. There we go. As background, the interrupted time series is a design that can be relied upon when the intervention or exposure does not allow for randomization. We require a clearly defined time point for our intervention, which is the date of a mass media campaign's release in this example, with multiple measurements both before and after the campaign, such as the number of monthly HIV tests. We can model the trend before the campaign, taking into account autocorrelation, which is the correlation between measurements over time. And we can project this trend into the post-interruption period as an indication of what would have occurred if the campaign had not been introduced. We can compare this predicted trend with the trend that was observed after the campaign's introduction. And using these elements, we can quantify the impact of the mass media campaign with a variety of effect metrics. So two examples of those here are an immediate change in level, or the step increase or decrease in the number of HIV tests. And another is the change in slope, where the trajectory of monthly HIV testing may change. So in a systematic review, we're all aware that we can extract the level changes from several studies that evaluate mass media campaigns and combine the effect estimates into a meta-analytic level change. The meta-analysis can be performed in two steps, where the first is to analyse each of the primary studies separately, extract the effects of interest, and then these are combined in a second stage via a meta-analysis technique to give us our pooled effect estimate. For ITS studies, the complexities arise in the first step, so the analysis of the ITS. And this step may be conducted by primary study authors, or the review authors may elect to reanalyze the ITS. But in both situations, the appropriateness of the ITS analysis needs to be assessed. For example, if autocorrelation is present, the wavy pattern in the data, then it should be taken into account. Analysis methods differ in whether and how they account for autocorrelation, and this can impact the conclusions that we draw from the study. Then at the meta-analysis level, the reviewer must select a meta-analysis method to combine the effect estimates from their included studies, and these differ in what we assume about the true effect. So for a fixed effect meta-analysis method, we assume that there is one true intervention effect and that the effect estimates from each of the studies varies due to sampling variability only. Compared to a random effects method, meta-analysis method, we assume that the variation between studies is made up from variation in the intervention effect and sampling variability. That means that using a random effects meta-analysis approach means that we must decide on an estimator to use for the between study variance, or tau squared, but also the method for estimating the confidence intervals of our meta-analytic effect. So we have, so when we're including ITS studies in a meta-analysis, there are two levels of analysis that we must consider: the ITS analysis level and the meta-analysis level. So this leads us to our research questions, which include: what is the impact of the ITS analysis method choice on the ultimate meta-analytic effect? And what are the conditions that might lead to a particular meta-analysis approach to perform better, such as the number of included studies, series length, autocorrelation, and heterogeneity? So these are the factors that we generated data for in our simulation. Our meta-analysis data sets vary factorially by 7 factors, leading to a large number of scenarios. So I'm only going to focus on a couple today. So scenarios might have 3, 5, or 20 interrupted time series studies per meta-analysis. And today we'll focus on scenarios where each ITS has 100 data points, so the longer series lengths. For our effect measures, each ITS study per meta-analysis will have a level change of 1, and where we have a heterogeneity of 0, the levels of each of the ITS within a meta-analysis will vary, but only due to random variation in the observations at each data point that we generate. This is compared to a heterogeneity of 0.3, where the variability between ITS will be greater because we'll be mimicking a scenario where the included studies are more heterogeneous. In this talk, we'll only look at scenarios where the ITS have zero autocorrelation, but I'm putting this up just to remind us of the additional complications with ITS studies. So in the full simulation study, each of the included ITS within each meta-analysis will be analysed with two methods. Firstly, all of them will be analysed with REML, restricted maximum likelihood, to account for autocorrelation, but also analysed with ordinary least squares, or OLS, to ignore autocorrelation. Today, we'll just limit ourselves to results where the ITS were analysed with REML. At the meta-analysis level, we compare a fixed effect meta-analysis method with 4 random effects approaches. Firstly, the popular Dersimonian and Laird with Wald-type confidence intervals, and also REML to estimate the between study variance. And for both between study variance estimators, we look at Knapp-Hartung method for estimating confidence intervals. Today, we'll just pick out 3 of these meta-analysis methods. So the fixed effect, Dersimonian and Laird with Wald-type confidence intervals, and REML with Knapp-Hartung confidence intervals. We'll also show results for the 95% confidence interval coverage of the meta-analytic level change as our performance comparison. So that is the proportion of the 1,000 simulations that the 95% confidence interval contains the true level change. So here we have plotted the coverage on our y-axis and compare the coverage with increasing amounts of heterogeneity, the tau squared, on the x-axis, for different number of studies as the panels. Each data point is a meta-analysis where all ITS were analysed with REML and then pooled with the 3 different meta-analysis methods, the 3 different coloured markers. We can see that when we have 3 ITS, so that we're looking at the far left panel, at all amounts of between study variation, pairing REML ITS analysis with a random effects meta-analysis achieved over or close to 95% coverage for our level change effect estimate. And that's good news. That's what we would hope for from our 95% confidence interval. But less good news is the drop in coverage for random effects meta-analysis with Wald-type confidence intervals when there is high between study variation. So that is the orange diamond. Using a fixed effect meta-analysis does not achieve 95% coverage, even with 0 heterogeneity. This is the blue squares. And it drops to 86% coverage when we have high heterogeneity. And this is as we would expect. With high heterogeneity, we see that REML with Knapp-Hartung confidence intervals, the green plus, has the highest coverage at or close to 95% at any number of included studies. And when we look at the interaction between heterogeneity and the number of included studies, we find that random effects meta-analysis is consistently achieving the highest coverage at all levels of heterogeneity and the number of studies, where REML with Knapp-Hartung confidence intervals, the green plus, is being the most consistent. When we have few included studies, both 3 and 5 included studies, that's the far left and the middle panel, Dersimonian and Laird with Wald-type confidence intervals, the orange diamond, decreases in performance as heterogeneity increases. But when we have 20 included ITS, it remains reasonably consistent. Fixed effect meta-analysis provides around 93% coverage at low or it's 93% coverage when we have low or no heterogeneity and decreases substantially in the presence of high heterogeneity, regardless of the number of included studies. So to summarise, we saw that regardless of the amount of heterogeneity or the number of included studies, random effects approaches had a higher 95% confidence interval coverage than fixed effect approaches. Further, using REML to estimate the between study variance and Knapp-Hartung confidence intervals consistently provided 95% coverage, even with high levels of heterogeneity, which is where the Dersimonian and Laird with Wald-type confidence intervals dips in performance. What we haven't had time to cover today is the importance of the ITS analysis method choice on performance. Meta-analysts should keep autocorrelation in mind when selecting their statistical method, because analysing ITS with REML will achieve higher coverage with long series lengths when autocorrelation is present. But reassuringly, using REML with Knapp-Hartung confidence intervals for meta-analysis may overcome issues that are introduced when ignoring autocorrelation during ITS analysis. So what have we added? This study is evaluating methods of ITS analysis that have only recently been investigated at the individual ITS level, and we are now exploring these and the performance of meta-analysis methods in the context of ITS studies. So thank you very much for your attention. Thanks also to my excellent supervisory team, teammates, and the Statistical Society of Australia, who supported me through my PhD and to present today. I'm happy to take any questions here if we have time. Otherwise, you can reach me on Twitter, email, or I think you can even chat through the platform that we have. Thank you.
That's excellent, Lizzie. Thank you very much for that presentation. That's a big simulation study with a lot of factors.
Yes.
If anyone has any questions, feel free to either pop your hand up or stick something in the chat. Just to get the ball rolling, we've got a couple of minutes here. You talked a little bit about using OLS and REML sort of for individual interrupted time series. You spoke mostly about the REML today. Is the ordinary least squares very different?
So great question. We have been exploring sort of the biggest difference. We find that they perform similarly to what we would expect out of studies that have been done on individual ITS studies alone. So when you then bring them into the meta-analysis, they perform similarly. And we see the same sort of patterns with their performance that we know happens when we've got so when we have few data points and no autocorrelation, we know that ordinary least squares performs better, and we see that as well. But what we are seeing with meta-analysis is that random effects meta-analysis actually gives us the coverage when we do have autocorrelation, because ordinary least squares is kind of creating heterogeneity that the random effects can deal with when we have autocorrelation. So there's a little bit of a protective effect in a way, but we still have more to hunt down and suss out as well.
Great, thanks. All right, in the absence of any more questions, again, oh, hang on, one's just coming from Phoebe. What are the future plans for further analysis?
Great question, great question. So there are other performance measures that we want to look into, particularly with this simulation study. But we also have a lot of those other combinations of the factors to have a look at as well. So the different number of series lengths we've got in there, different amounts of heterogeneity. We also want to look at slope change, and that's for the simulation study. And we've also been able to get our hands on some empirical data that we're going to also use these methods on to see what the effects are in real life. Thanks for the question, Phoebe.
That's great. Thank you very much for that. Again, feel free to put your questions in the chat. And we'll now move on. Lizzie, if you wouldn't mind stopping your screen share. And next,
my little Zoom thing. There it is.
Next up, we have Tim Barker.
There we go. All right. Thank you, Simon. Hopefully everyone can see my screen. Hello, my name is Dr. Tim Barker. I am a research fellow working at JBI, and I'm presenting to you today about proportional meta-analysis on behalf of the JBI PERSIST methods group. In this talk, I'm really going to be talking about the uses of proportional meta-analysis in different review types, so when we might use it and its importance and its benefits over traditional comparative meta-analysis. I'm not necessarily going into the specifics of how to conduct these, rather their benefits and when we can conduct them. Before I begin, I just need to disclose that I am an employee at JBI. They pay my salary. I'm also a member of the Grade Working Group and the JBI Adelaide Grade Centres. And JBI do have a commercial partnership with Wolters Kluwer Health and Ovid. They are our book publisher. and they are our commercial partner for the sales of JBI Summary, which is a software program that we offer at JBI. So I guess we don't really need this slide, just given the talks that we've had, but comparative meta-analysis, as you all aware, is how we can combine, it's a common method of synthesis to combine quantitative data from 2 or more independent but comparable studies. Now, most meta-analyses, and most of them that we've talked about today, are comparative. They're looking at the differences between 2 groups. Normally, we're looking at the effects of interventions between group 1 and group 2. And we're looking at the effects of these interventions on the outcomes. However, there are also approaches to do meta-analysis of single group data, and this is typically our descriptive data. Now, what I've got pictured up here, I'll just get my laser pointer up, is our typical comparative meta-analysis forest plot that we're all familiar with. At the bottom here, we have our proportional meta-analysis. And I'll just very quickly run through this just in case anyone's not familiar with these types of forest plots for this meta-analysis type. The biggest difference that you'll notice is that we don't have events and total per each group. We've just got one group. This is single group data. Now, what these would represent is the total number of events of a certain outcome or event or condition against the total number of people that were actually measured. Now, as you can imagine, this is typically coming from descriptive studies, our cross-sectional studies, and so on. So, for example, the Dewey study is showing that 10 people out of 450 people experienced this outcome, Lang 14 out of 530, and Saji 310 out of 3018. This can be converted to about 2.2% of people in the Dewey study, 2.6% of people in the Lang study, and 10.3% of people in the Saji study experienced this outcome. And so what we're doing by combining in a proportional meta-analysis is collecting information about a global burden of this particular disease or health outcome, what have you. So by combining all this information together, we see that there is about 7.9% of people that experienced this health outcome of all the studies that contributed data towards this meta-analysis. That's a very, very brief introduction into what we're seeing when we're looking at the forest plots of proportional meta-analysis. But let's get into the real meat of this presentation. When and why we would ever want to conduct a proportional meta-analysis. And doing a proportional meta-analysis is controversial because there are very true differences in the studies that we're combining as part of a proportional meta-analysis in terms of their populations of people that were involved, the measurement instrument used to measure the outcome or the health condition of interest, but importantly is time. Time is a component that is very unique to proportional data. And when we collect proportional data, it is normally through our descriptive studies, normally through our cross-sectional studies, which take a snapshot of a population at a given point in time. And we're collecting information about cumulative incidence of a disease or prevalence of a disease. Now, that's all very dependent on this time variable. However, at JBI, we do think that for a systematic review in which the objective of that review is to estimate global burdens of disease, then proportional meta-analysis is still appropriate. And we would do this commonly in a systematic review of prevalence or incidence. So in these types of systematic reviews, we are collecting data from multiple different studies that we've included, and we're trying to provide a single summary estimate of the prevalence or incidence of a certain health condition across these included studies. So it gives us this indication as to what we might call the global burden of this condition. So I've got a few examples of when we might do this for a systematic review of prevalence and incidence. This comes from a systematic review conducted in Brazil. And this was looking at the prevalence of cervical infection in patients that had HPV-18. So what they did was they looked at the number of people that had cervical infection with this disease across all these different studies that were conducted in a Brazilian population over a certain number of years. And what they've done is they've calculated that the average number of people that had cervical infection with HPV disease was about 1.8%. So based on this research and based on the evidence that was summarized in this proportional meta-analysis, the authors are able to suggest how public health efforts can be specifically targeted. So they suggested that these public health efforts can be targeted towards specific regions and populations that might experience higher HPV prevalence compared to others. I have a second example. This is an example from a systematic review that was investigating premature scan terminations in MRI due to claustrophobia. So what this systematic review was interested in was, of all the MRI scans that are conducted, how many of them are prematurely cancelled? So cancelled before the MRI scan is completed, but specifically cancelled because the person that was getting their MRI suffered from a claustrophobic event. Now, what they've done is that they've calculated from each study the number of times the MRI scan was cancelled over how many scans were actually performed, and they've generated their own proportions or percentages of these numbers here. They can then calculate the global burden of MRI premature cancellations of all the studies that were combined, and we can see that about 1.1% of all MRI scans that were conducted, based on information that was included in this proportional meta-analysis, was cancelled due to this person suffering from a claustrophobic event. Now, again, this can be used to inform how we deal with people that might suffer from claustrophobia, and inform people that are radiologists and people that are doing these scans, give them an indication as to the amount of people that might experience claustrophobia when they're going through these types of scans. Now, a more controversial idea is that we can also use proportional meta-analyses for our systematic reviews of interventions and therapies. Now, this isn't common, and it's not necessarily advised if you have evidence that would facilitate a comparative meta-analysis. As I said at the top, the data that we're collecting that would facilitate a proportional meta-analysis normally comes from our lower level of evidence, normally comes from our descriptive studies and not our RCTs. However, when we're lacking information about a particular, when we're lacking evidence, I should say, from a higher form of evidence, we can still use proportional meta-analysis to inform decision-making. This is an example of a systematic review looking at revision surgery for people that had hemi or total hip arthroplasty, and it's come from surgery. Now, surgery, it's a field with famously not many RCTs available. So what this systematic review did was just look at how many surgeries that were performed, how many of them achieved total revision. So as you can see in the Canberra study, 100% of the surgeries that were performed did achieve a union. They were successful. So again, this can be used to inform decision-making as to how successful this particular intervention can be. Again, it's not necessary to say it supersedes comparative data, but it is an option when comparative data isn't available. Now, before I end, I just want to talk about one improper use of proportional meta-analysis, and that is for systematic reviews of diagnostic test accuracy. It has been done previously where proportional meta-analysis has been used to pull the effects, to pull sensitivity data and specificity data separately. And this is not correct. It doesn't appropriately account for the relationship that exists between sensitivity and specificity, which will lead to an inaccurate estimate of your test, of your diagnostic test. And so if you encounter a diagnostic test that has pulled sensitivity and specificity data separately using a proportional meta-analysis, please interpret those reviews with extreme caution. So thank you very much for the opportunity to talk today. I know that was a very quick run through of when we might use proportional meta-analysis. This is all based on information that I have published in the methods paper in the BMC Medical Research Methods. And in that paper, it does go into more more specifics about how to do these, the models and statistical formula that you can use, transformation, publication, funnel plots, subgrouping. And so if you're interested in proportional meta-analysis, I strongly do encourage you to look at our paper. It's available at this DOI. But otherwise, thank you very much for the opportunity to talk today.
Excellent, thanks, Tim. We've got questions coming in straight away. So our first question is from Mason. It says, thanks for the great talk. Is this appropriate to use for prognostic systematic review?
Yes, and if I had permission to use it, there was a great example of, I think it was the Center, I don't want to get the name wrong, but there was a very recently published prognostic, a prognostic systematic review that looked at COVID mortality and prognostic factors for that, and it was published as a proportional meta-analysis. If I had permission to share the example, I would have included it in the talk, but it wasn't under Creative Commons, and so I couldn't. Again, it's referenced in my paper, and so if you're interested in that example, have a look at the paper.
Great, thanks. Another question from Emily. Could you comment on the interpretation of heterogeneity in these types of meta-analyses? I noticed that too, the first few examples, they had quite significant heterogeneity.
Yeah, okay, so a couple of things there. One, in those few examples, they're very significant heterogeneity, but when we're looking at the raw numbers, I'll even jump back to the slide. If we're looking at this one, if we're looking at the raw numbers here, we're looking at such small proportions of people. And so when we have very precise data like this and our confidence intervals don't overlap, it tends to exaggerate our I-squared. Saying that, there are no specific tests to assess heterogeneity for proportional meta-analysis yet. We do suggest the I-squared currently, but keeping in mind that with proportional data such as this, we typically see this very precise data that may exaggerate a high squared. And so in the context of proportional meta-analysis, a high I-squared won't necessarily mean that the data is inconsistent as it might with comparative meta-analysis. And so we would again encourage you to interpret this very conservatively. And like we've already discussed, the chi-squared and the tau squared can also be used to investigate heterogeneity, but there are no specific tests yet specific to proportional meta-analysis.
Great, and one technical question from John Luca here. Says, we usually rely on Metaprop and Metaprop1 in Stata MA models, but often they have issues on how tau is estimated. Are there any updates on that, or what are your thoughts on
if I could speak to it, I would have a response. I'm sorry, I've never used any of those programs. I think it looks like that. I'm guessing they're programs. I'm not sure. And I'm not particularly sure on how tau would be estimated. Sorry.
Do you have particular software that you
yes
hesitantly recommend?
I would, yes. That's a better question. So you can do this in JBI Summary. That's not a shameless plug for JBI's software, but you can do this in JBI Summary. You can also do this in Meta Excel. I use the various R packages, but StatsDirect, MedCalc. You can do it in Stata, but I've never used Stata previously, so I can't specifically speak to it.
That's great, thank you.
That's okay.
Thank you very much, Tim. Our final presentation today is from Joanne.
Thanks very much, Simon. Hopefully you can see my screen.
Yeah.
So what I'm going to talk on today is random effects meta-analysis methods in RevMan, evidence-based recommendations for the implementation of new methods. I'm based at the Methods and Evidence Synthesis Unit within the School of Public Health and Preventive Medicine at Monash University. And this work represents basically around 2 years work from the team of people, many of whom are conveners of the Cochrane Methods Cochrane Statistical Methods Group, and I'm presenting on their behalf today these recommendations. And I'll talk more about their role as I move on the presentation. So declarations of interest, I have a couple of roles within Cochrane, and I'm also funded to undertake research on evidence and statistical methodology by the NHMRC through a career development fellowship. So we've already heard a bit about random effects meta-analysis in the preceding presentations, but just to recap, in a random effects model, we assume that every study is estimating its own true intervention effect, and that can vary across studies. And these studies or these intervention effects are linked through a distribution, which we often assume is normally distributed. The center of that distribution is represented by mu, and that distribution has a mean, standard deviation, which we represent by tau. So let's consider a particular example. Here is educational interventions directed at health professionals to improve control of blood pressure in patients with hypertension. And what we have is a series of study here with odds ratios. Now, when I fit a random effects model, what I might be interested in doing, generally I will be interested, is estimating the center of that distribution of those intervention effects. So calculating a summary effect and of course a confidence interval for that summary effect. To do that, I also need to calculate a between study variance, which we denote by tau squared. And I might be interested in also calculating a confidence interval around tau squared, which tells me how certain I am about around the estimate. And I might also be interested in calculating a prediction interval, which gives us the predicted range for the true treatment effect in an individual study. And of course, there are lots of other statistics I could calculate, for example, I squared. So bringing back these estimates of odds ratios from the set of studies, what I would typically do is fit a random effects model, and often the standard method that we have available and has been available for over 30 years is the Durr, Simonian and Laird random effects method. I'll refer to that as the standard method throughout. And that essentially has two components. It estimates the heterogeneity variance using the method of moments estimator, and it also uses a Wald-type confidence interval method to calculate the confidence interval. And it's currently the only random effects method that's implemented in RevMan, which is Cochrane's software for producing systematic reviews. But actually there are a whole range of other methods available. And we can see the results of these other methods here. These methods all use a Wald-type confidence interval, but they use different methods for calculating the heterogeneity variance. And what you can see here is the first three methods actually provide a similar estimate of tau squared, but these latter two methods provide a smaller estimate of tau squared. And this has implications for the width of the confidence interval for the summary effect. So up here, for the first three methods, the confidence intervals tend to be wider than for these latter two methods. So for any particular meta-analysis, the estimated parameters, the summary effect, heterogeneity variance, and so forth, may differ depending on the particular methods that we actually use. So the Durr, Simonian and Laird random effects method, we know has had unfavourable statistical properties. By this, I mean that it produces p-values that are often too small and confidence intervals that are too narrow. And this particularly happens in certain circumstances. So where we have few studies in the meta-analysis, those studies tend to be small. We have rare events, and we might have moderate to high underlying heterogeneity. The problem is that in Cochrane reviews, few studies is a relatively common event. So in one empirical investigation, the median number of studies per meta-analysis was identified as 4. Outside of Cochrane the reviews, the number of studies included in meta-analysis tend to be a little bit higher. To kind of deal with the problem of the standard random effects meta-analysis method, there's been lots of alternative methods developed. And these two systematic reviews here have kind of summarized these. So you can see there are greater than 16 heterogeneity variance estimators and more than 15 confidence interval methods. So which method should we adopt in Cochrane reviews and implement in RevMan? So that leads me to the objectives, which are twofold. The first is to provide recommendations for random effects methods to be implemented in RevMan. And specifically, these recommendations are around the heterogeneity variance estimators, confidence interval method for the heterogeneity variance, confidence interval method for the summary effect, and for the prediction interval method. And the second objective is to examine the impact of adopting the recommendations on confidence intervals and p-values for the summary effect of meta-analyses in the Cochrane Library. And these bolded pieces of text here indicate what I'm going to speak to in the rest of the presentation. So just to briefly go through the methods, we broadly have followed 4 steps. The first step is to update systematic reviews of statistical simulation studies that have examined the performance of heterogeneity estimators and confidence interval methods for the summary effect size. Over the last 2 years, we've had multiple meetings amongst the team to review the evidence and to form recommendations. And we've examined the impact of adopting those recommendations by applying them to meta-analysis in the Cochrane Library. And then the final step is to submit these recommendations and evidence to the Cochrane Scientific Committee, who will determine whether these methods should be implemented in RevMan. And we also want to seek feedback from the broader statistical community. Obviously, the outcomes of these consultations may lead to revision of the recommendations in step 2. So just to talk a little bit more about the team and our experience, many of us are co-conveners of the Cochrane Statistical Methods Group. There's multiple of us have led systematic reviews of statistical simulation studies and undertaken simulation studies on this topic. So RG, Dean and Mark fall into that category. We've led empirical evaluations examining the impact of using different methods, and Simon, who's chairing this session, has done this. Also, Mark and Dean have also done work on this. And we also have a liaison with the Cochrane Method Support Unit through Kerry Dwan. So what are our recommendations? Well, I don't really have time to talk to the specific details of these, but what we are recommending is that the restricted maximum likelihood heterogeneity variance estimator should be implemented as the new default method. It's shown to give yield marginally better estimates than the Durr-Simonian-Laird method in meta-analyses that have characteristics similar to those in Cochrane reviews. For the confidence interval, for the summary effect size, our recommendation will really be dependent on 2 factors, the number of studies and the estimate of heterogeneity variance. And this has been quite hard to come up with these recommendations. We've almost had to find a bit of a sweet spot between confidence intervals that will be anti-conservative and overly conservative. So let's just have a brief look at the impact on these results. So I've got a series of plots here. Thanks very much to Simon who's produced these. And I just want to provide some orientation to these plots. So basically they compare scaled confidence widths between pairs of the confidence interval methods. Each vertical line represents a comparison for one meta-analysis. And there are over 2,000 meta-analyses presented in each of these plots. So the confidence interval for the reference method will span between -0.5 and 0.5. And so this is denoted, you can see in this yellow area here. And when we have vertical lines that extend beyond the shaded area, it indicates that the comparator method confidence intervals are larger than the reference method. So with that in mind, I just want to talk through 2 of these plots. This is the first plot here. So our reference method here is the standard method. So the method that's currently implemented in RevMan. And what we're comparing is the REML method with a Wald type confidence interval. So the key points to really note here is that essentially, even though if I just look at changing the heterogeneity variance estimator to REML, really the confidence intervals don't substantially change. So we can see that they are slightly bigger for a smaller proportion, but essentially they're very similar. But this is really the key comparison that I'm highlighting here. This is comparing what our recommended confidence interval method will be to be implemented in RevMan compared with the standard Wald type method that's currently there and using the Durr-Simonian and Laird heterogeneity variance estimator. And what you can see here is that the confidence intervals using this new recommended method will be at least as wide as what they currently are. And in fact, for a large proportion of meta-analyses, using the new recommended method will result in much wider confidence intervals. So in conclusion, the Dersimonian-led random effects meta-analysis method can be misleading. This is particularly the case in meta-analyses with few studies, which is a common problem within Cochrane reviews. We know that there are alternative methods that are more optimal. We've undertaken systematic reviews of statistical simulation evidence, and this has led us to formulate evidence-based recommendations for the implementation of new random effects methods within RevMan. The implementation of these methods will appropriately, and I emphasize appropriately, lead to more conservative results. So we'll end up with meta-analyses for the summary effect that have wider confidence intervals and larger p-values. And in some reviews, this of course may lead to changes in the conclusion. So I have some references here, and I'd welcome any questions. Thank you.
Thanks, Jo. Floor is open for questions. And as a matter of fact, here's one in already. Thanks, Jo. Great talk. As the methods of choice depend on the number of studies, does it mean that sensitivity analysis may opt for a different method?
Look, I mean, I think it's always helpful to undertake sensitivity analyses, but I guess what we're trying to aim for in these recommendations is to provide methods that we think will be kind of optimally okay. In any particular meta-analysis, of course, you can apply a range of methods and you never know which one of those is closer to the truth. We're always in these statistical simulation studies trying to work out what will generally be the best method.
Steve's added a question here. Does this mean that the new method will mitigate the small study effects we see?
So no, I mean, no, it won't mitigate small study effects. So, you know, if we have still small studies showing us different effects to larger studies, so where we kind of have suppression of results occurring or for other reasons, the random effects model is always going to be prone to this particular issue. But what it will do is, I guess, we will tend to see wider confidence intervals. So given we have these wider confidence intervals, hopefully that will mean that review authors would be perhaps less optimistic about the effects of certain interventions when those effects probably are just due to problems with the random effects method.
Less emphatic on those differences, I guess.
Yes, that's right. So shall I? So Matt's.
Yes, Matt's got one here.
Yep.
Have you submitted these results to the Cochrane Scientific Committee yet? If so, how long do you expect it would take to implement changes in RevMan? That's a good question, Matt.
Very good question. We're very close to submitting the document to the scientific committee. Once that arrives there, I really couldn't judge how long it would take to kind of move through the process.
Excellent. Well, that was a fascinating batch of talks there, and we've made it on time with no technical difficulties. So I think that's excellent work. I just want to wrap up by thanking all of the presenters on behalf of all of us here. It's always fascinating to be in a position to see and hear the research that's been going on in statistical methodology. Thank you all so much. Feel free to continue on in the chat for a minute or two if you still have another question. And I look forward to all the other sessions that we're going to come along in the next couple of days. Thank you very much.